at the southern. Hello, everyone, and good afternoon. Thank you for welcoming me for this presentation. This afternoon, I'll be presenting on type 2 diabetes mellitus, which is commonly known as sugar in the Caribbean. And I'll be presenting some of my doctoral work, which was conducted in Trinidad and Tobago, which is the southern island in the Caribbean. So type 2 diabetes mellitus is commonly known as sugar, and it is the second most common cause of death in Trinidad and Tobago. It has the highest estimated prevalence amongst Indian Trinidadian descent population members over the age of 50 years. And the research I conducted was in the semi-urban region of Debe, which is in the southern part of the island. Type 2 diabetes, for some people who were diagnosed, produced different ways of engaging with this diagnosis. Some identified with this clinical definition, and it produced new forms of practice and belonging in accordance with a more biomedicalized framing of their experiences as patients. In contrast, many others did not identify with the clinical diagnosis and continued to practice few to none of the self-management recommendations from the clinical practices to which they were subscribed. Those who identified as diabetic engaged in a form of biological citizenship, or a form of belonging, rights, claims, and a political subjectivity that is consistent with and derives power from a biomedicalized description of their body, habitus, and experience. And by this concept of biological citizenship, I'm drawing, of course, on Foucault's constructs of biopower and medicalization, and later their rearticulation by Nicholas Rose and others to describe the complex interactions between the human body, the politics, economics, and sociology of the environment in which the body exists. So type 2 diabetes, for some people in Debe, produces new forms of belonging in accordance with this framing of their experiences as a diabetic patient. They engaged medical practices, changed diets and exercise to be concordant with medical recommendations, and became good patients, compliant with the strictures and directives of what medicine deemed diabetic practices. In contrast, others in Debe were clinically diagnosed as diabetic and yet did not identify with this diagnosis at all. They changed their practices little to incorporate the clinical self-management recommendations. And this latter group commonly was labeled as not compliant by the medical establishment. It is this group on which I focus today in an attempt to problematize this category or this label of non-compliance by historicizing the health-related structural violence to which this community has been subject. I briefly describe, finally, in this paper, the communal practices specifically around diet that have facilitated social cohesion and support in the face of multiple forms of structural violence to which this community has been subject. By focusing on these two key concepts of structural violence and forms of communal resistance, I seek to untangle what is at stake in the normative biomedical diagnosis of diabetes in Debe, and how identities are negotiated to include or exclude this diagnosis. Does not assuming the normative biological citizenship of being diabetic in Debe result in being labeled compliant? Conversely, does assuming a diabetic identity result in alienation from deeply supportive, rooted practices of religious and communal engagement that are forms of resistance to structural violence? I argue that acting directly in contrast to the diabetes management recommendations in some ways constitutes an affirming form of community cohesion that is not considered enough in the construction of the diabetic patient in Trinidad. So first, I'll contextualize the field site a bit more. Trinidad, this island, is one of a twin island republic, which, as you saw before, is located at the foot of the Caribbean arc. It is the larger of the twin island republic, and it was initially a Spanish colony. Then it was subject to an influx of French settlers and slaves in the 1780s, and then it became the last major British conquest in 1797. After British emancipation of the slaves, a new labor source was needed to develop its undeveloped sugarcane plantations, and this was found in indentured laborers were primarily drawn from India, and 147,000 approximately were taken to Trinidad from 1845 to 1917. And in Trinidad, the Indians met an existing population that was already diverse, consisting of migrants, indigenous inhabitants, and an existing educated and urban Black and colored and white middle and upper class. So ethnic identity, or as it is commonly referred to in Trinidad, race, is a key element of the popular discourse locally. There are two major ethnic groups commonly identified: the indentures, the descendants of Indian indentured laborers, labeled by the Central Statistical Office as Indian, and the descendants of African slaves, labeled by the Central Statistical Office as African or Black. Each group is estimated to constitute about 35% of the population. And the next largest group is the mixed Indian Black or mixed other group, which is roughly 15% of the population. There are also much smaller percentages of Caucasians, usually of colonial descent, Chinese, indigenous, Syrian, Lebanese, Portuguese, and other groups. Today, Trinidad is a multi-ethnic, English-speaking democratic republic. It has a population of about 1.3 million, of which only 60,000 live in Tobago, our sister island. Trinidad's economy since the 1960s has been reliant on oil and gas, having large crude oil reserves and natural gas as well. It was ranked by the OECD as a high-income country in 2011, a category which many Trinidadians continue to dispute. And it has a nationalized system of free public healthcare distributed through 3 tertiary hospitals and a network of local health centers across the country, including in Davie. This coexists with a system of pay-for-private healthcare that has been growing exponentially since the 1990s. This research was conducted in Davie, which is, as you can see in red, this area in Trinidad down here. This is a map from the Ministry of Planning and Housing. And Davie was formed as a farming village on the outskirts of adjacent sugarcane estates in the 1800s by time-expired Indian indentured laborers who settled in Trinidad as farmers after indenture and continued to support the sugarcane industry as tenant farmers. The communities in Davie are also underlain by strong kin associations as families settle near each other in a linear pattern along the major transit routes for transporting sugarcane from these hinterlands or from these areas where the sugarcane was grown to the capital city for shipping. Today, it is mainly settled by Indian Trinidadians, descendants of indentured laborers who were the backbone of the agricultural industry. Indeed, the Statistical Office says that approximately 71% of the population of Davie identify as Indian, which is a higher percentage than the national average. And the percentage of Hindus in Davie is considerably higher than the national average. The national average is 18.2, And in Debe, it is 42% of the population that identifies as Hindu. While Hindus are the second largest denomination in the larger Trinidad populace, behind the Roman Catholics at 21.6, Hindus are 18.2% of the national of all the religious denominations. However, in general, the proportion of Christian denominations is much larger in Trinidad than the total Hindu percentages. Since 2003, a bit more history to in 2003, the nationalized agricultural industry, known as County 1975 Limited, was shut down by the then government. This included retrenching 9,000 plus workers who had historically been farmers, tenant farmers, and renting land from this national body, this national farming body that was responsible for administering all the agriculture throughout the country. Prior to this, however, employment in sugarcane and in the sugarcane industry had already been quite low. Despite this, the region of Debe, Pinal, and more areas along what is called the sugarcane belt of Trinidad has very deep agricultural roots. These agricultural roots linger in the communal rhythms of life. And also of significance, the proportion of people over 50 years of age who were engaged in this research and who continue to be primarily diagnosed as type 2 diabetics are the last generation to have direct experience of sugarcane agriculture in the area. So for this paper, I draw upon fieldwork conducted from 2013 to 2017, obtained through ethnographic participant observation, interviews, and archival research. Much of this research was informed by being a Trinidadian of Indian descent myself, and by being a medical physician in that context. I will first discuss the construction of diabetes in Trinidad, and then I will contextualize the ways that structural violence continues to act on the bodies of people in Debe. And finally, I will discuss the forms of communal cohesion that produce resistance to this violence. So Debe was chosen as a field site because one of its local health centers is estimated to have the greatest number of diabetics registered to its free weekly chronic disease clinic. These weekly chronic disease clinics are the main means by which people with diabetes in the area receive continuous care. Compared to other Latin American and Caribbean countries, Trinidad and Tobago has a higher death and disability rate because of diabetes. Diabetes has consistently been the second leading cause of death in Trinidad and Tobago after other cardiovascular diseases, such as heart attacks and strokes, to which it also contributes as a comorbidity. In comparison, most Caribbean and South American countries, such as Nicaragua, Paraguay, and Venezuela, diabetes and complications are the third to fourth leading cause of death. Type 2 diabetes is a condition caused by an abnormal elevation of blood glucose levels due to abnormalities in insulin functioning or production. Medically, diabetes may be present for years without people experiencing any obvious symptoms of it. During the asymptomatic period, it can nevertheless be diagnosed by the use of medical measuring devices without having yet this diagnosis may not reflect patient experiences. Thus, patients may be diagnosed with the disease of diabetes without having any of what Kleinman and others have defined as the illness experience of changes to their lives and practices. For those diagnosed with diabetes, long-term changes to diet and exercise patterns are standard medical recommendations for self-management in combination with medication regimens that vary with disease severity, from solely oral agents to insulin injection administration. Diabetes was one of the first diseases to be associated with a specific race or racial profile in Trinidad. There were two classic studies. The first in 1961 to 1962 by Poon King sampled the blood and urine of 23,900 Trinidadians after a glucose challenge to assess for the presence of type 2 diabetes. This found that the prevalence rates for East Indians, Negroes, and mixed races over 20 years old were 4.5, 2.5, and 4.4 respectively. And further, that in East Indians of 55 to 59 years of age, the rate was as high as 14.7%. 15 years later, in 1977-85, Beckles et al. Performed a longitudinal survey of 1,416 men and 1,100 women, which confirmed a striking racial difference in diabetes prevalence, with the prevalence being higher amongst the Indian descent population. In my experience as a young medical student and a physician in the public health sector, I commonly encountered characterization of diabetic patients as non-compliant with medical recommendations for their diabetes management. What physicians considered non-compliant ranged from not altering their lifestyles, including their diets, to not exercising regularly, to not taking their medications as prescribed, to not coming to the clinics on a regular schedule. The diabetogenic diets that were targeted as specifically at high risk of causing or perpetuating diabetes were targeted many of the sweet foods associated with Hindu religious observance and the everyday foods of a typical lower income Trinidadian Indian diet. These foods contain carbohydrates that are rapidly metabolized, such as white flour and white rice. In the medical establishment, the concept of non-compliance has been critiqued widely for invoking the paternalistic authority of the physician and localizing within the patient's realm of control dimensions of their illness experience, which are attributed to them as individual moral failings. Despite this, poor compliance or non-compliance was commonly found in patient notes for those whose test results showed no improvements even after successive attempts at treatment. The wards of public hospitals, additionally, were filled with patients whose medical records bulged with successive notes stating non-compliant. For many of these patients, the consequences of their perceived non-compliance were dire, ranging from amputation to kidney failure, blindness, heart attacks, and strokes. Trinidad and Tobago also have one of the highest rates of lower extremity amputations secondary to diabetes in the Caribbean, and the rates of amputation have continued to increase. So to problematize this category of non-compliance, I draw upon Paul Farmer's re-articulation of the concept of structural violence. I use this concept to think through and complicate the presence, distribution, and engagement of people with diabetes within their geographic and political social landscapes. The embedded processes that are both material and social, constitutive of and constituted by structures such as the built and lived environment and the formal and informal healthcare systems and practices, such as the work of living, accessing caregiving in formal and informal contexts. Structural violence is violence exerted systematically, that is, indirectly, by everyone who belongs to a certain social order. Hence, the discomfort these ideas provoke in a moral economy still geared to pinning praise or blame on individual actors. This violence emerges from an unequal distribution of power and resources, and as such can be understood as some of the forces that act to produce health inequities. At the national scale, South Trinidad and on the whole, and Diabetogenic in particular, are heir to a structural violence that has skewed the access of the working class Trinidadians who live there to the purportedly free nationalized system of preventative healthcare. This system of healthcare is paid for by a percentage of Trinidad's GDP and individual taxes. In practice, the healthcare system is two-tiered. There are free nationalized healthcare settings of all levels previously, from the primary to the tertiary level, which all citizens can access. And there is also private fee-for-service healthcare available through private institutions that may be covered by employer-based health insurance, but is also paid for out of pocket. The two-tiered private-public healthcare sector of Trinidad and Tobago has colonial historical roots. Private physicians were responsible for catering to the needs of the elite planter class, while hospital and institutional-based care was geared towards the lower and laboring classes. Post-independence, the government built state-of-the-art public hospitals accessible to all without a fee-for-service and created a network of health centers to provide primary and preventative care to the dispersed population of the country. However, the geographic distribution of the public healthcare sector and tertiary care hospitals reveals continuing disparities between the north and south of Trinidad. And these disparities exist in access to power, goods, and services, and they constitute a form of structural violence with roots in our colonial past. During British colonialism, the capital city, Port of Spain, and the east to west corridor along the major transit routes were primarily settled by elite planters and colonists. These were the first to receive services, infrastructure to support these services. South Trinidad was viewed as a source of extractive wealth, such as sugar and later oil, rather than a site for investing resources, including schools and hospitals. This was despite the region having been settled by roughly half the population from the colonial period onward. After independence from Britain in 1962, the more urban and elite North Trinidad continued to receive a greater proportion of the national development funds and attention in the form of further infrastructural and municipal development. This included the construction of tertiary care hospitals and a higher proportion of health centers for primary and preventative health care to the population size. In the last 20 years, new health centers, outreach centers, district health facilities, and hospitals have been built. However, these inequities have still not been fully addressed. At the national policy level, the decision-making behind healthcare delivery is another example of the structural violence to which South Trinidad has been subject. In the 1980s, the IMF advocated for new, more economically rational healthcare policies that resulted in a fragmentation of the centralized health service system in Trinidad, as it did in other lower to middle income countries around the world. Instead of a centralized Ministry of Health responsible for healthcare policy and healthcare resource allocation across the country, 5 geographically delimited regional health authorities were introduced in 1994 to be run with the same principles as financial corporations. The Southwest Regional Health Authority was formed with responsibility for the largest landmass and the largest population catchment of 600,000 people. Within the regional health authorities, the job security of health workers decreased as their status changed from state contract employees and from state to contract employees, and thus free agents. A steady flight of physicians to private practice began to occur, decreasing the workforce in the public sector and further increasing the proliferation of private health facilities. An estimated 75 to 90% of the middle and upper classes in Trinidad solely access private healthcare currently. This is further facilitated by employment-based health insurance policies. The chronic understaffing of the public health sector increases wait times in clinical settings, especially the overburdened chronic disease clinics. This increases patient loads and decreases patient consultation times. In the Bebe Health Clinic, where chronic disease patients are seen, a single doctor is often responsible for seeing 50 plus patients on a single morning. Consequently, there has been a decrease in the level of care available to the lower working classes, deepening health access inequities. These forms of structural violence are also deeply imbricated in Trinidad with practices that have consistently othered the non-Christian Indian Trinidadian population, especially the Hindu segment of the population, which is non-Abrahamic, from their early relegation and confinement to the grounds of plantations, which they could not leave without permits, to the lack of legalization of Hindu marriages until 1945, when a Hindu Marriage Act was passed. There have consistently been attempts at conversion and proselytization by major Christian groups as well that target Hindus. It is not a far stretch to see the modern day functions of structural violence that we highlight as also co-constitutive of racist policies that disenfranchise patients and peoples living in these locations who were primarily of Indian descent. In this last section, I will briefly provide an overview of dietary practices and how they have worked with communal practices as forms of resistance to the structural violence and disenfranchisement which the community in Debe has been subject to. At a micro scale, the non-compliant bodies who did not ascribe to a biological citizenship of being diabetic universally participated in specific forms of religio-cultural practices that I will describe now. The everyday task of food, firstly, preparation, dispensing, planning, and organization was markedly gendered and most commonly occurred in the private space of the home. It was unwaged, rendered invisible, and categorized as women's work. And this is something that the invisible work of the home is something that, of course, feminist scholars have long noted. In the rural context of Debe, however, additionally, the work of food preparation extended beyond the home for communal celebrations at which sharing group meals was a necessary and ritualized part of the observation. For example, are you seeing that? Yeah. For example, for Hindu observances in the village, there would be communal food preparation where a group of women would get together at a centralized site, whether it was the temple where the prayers were going to be held, or someone's house where an event like prayers or a wedding was going to be held. And they would pull out these enormous pots that are used for communal cooking, and they would gather lots of ingredients and they would cook together. These religious observances were often multiple nights in duration, and they included things like Ramayana Yagyas, which were group discussions of the Hindu myth, the Ramayana, satsangs, which were song-filled ritual prayer ceremonies, and other pujas. Prior to all these events, women would gather to wash, peel, cut, grind, blend, dice, and eventually cook the large communal meals that would be later consumed, most commonly on the same day. This preparation work was understood to be part of the responsibility and the privilege of belonging to the community. There was a common understanding that belonging to the community entitled one to participate and partake in these events, both the activities and the fruits of all that labor, which included the meals. These meals would often feed between 100 to 200 people for each of these events. In its communal, feminine-centric space, the labor of the whole was extended, and it assumed a different significance when the participants were diabetic. The communal meals also materially reiterated integral forms of sociality, affirming bonds of camaraderie, reciprocity, and kinship within the village setting. They consolidated identity, as is common amongst diasporic communities internationally. So these practices of communal commensality were recapitulated multiple times a year in Debi, and they continued to reaffirm to people a sense of belonging, a sense of kinship, and a sense of responsibility and caring that were often absent from the other settings in which people engaged. For persons in Debi with type 2 diabetes who self-identified as good patients or who described themselves as trying to control their diabetes with lifestyle practices, a common issue was how they could or could not continue to engage with the communal cooking and eating practices that created close cohesion and reciprocity in the villages. For example, Tara, one of the women I spoke with, was given a drop or was taken by car to the clinics by her friends and family, who she later cooked with for all of these events. She felt a deep sense of alienation from community when she was directed by her medical physician not partake in these diabetogenic foods, which included lots of white roti or unleavened bread and white rice, highly spiced oily foods, and even the ritual foods that are prepared, like mohan bhog or prasad, are made with a lot of white sugar. So this alienation from community and unwillingness to alienate themselves from community in order to be a good diabetic is something that, which is something that I would love to describe in more depth, but I think I'm at the end of my time. So how people resolve this in various ways, reconcile these identities, is explored further in my dissertation, and I'd love to discuss it more with you through questions. Thank you very much.
Thank you very much. Fascinating.